Hi, David. Hello. Just don't have any sound for you. David, at the bottom of your bottom left, do you have a microphone button? It's either on or off. There you go.
Hello?
Hi.
Can you hear me okay?
Yes, I can.
All right.
Yeah. How are you today?
Good.
Good.
So you're having a lot of excitement?
Yeah. Yeah, I keep reminding myself that this fix is very small compared to what you all are dealing with at the hospital. It was a lot of problems, I guess.
Yeah, yesterday was a mess. I think I wasn't on service, so I only saw it through emails and such. But
Yeah.
now, are you going to show the slides or slides and video, or how are you going to do it?
So I'm going to share these with you, and you can you see them at this point?
Yeah, I do see them.
Great. So then I will share the control with you, and
So where are you physically? Are
I'm
you
at
at the
home.
Friday Center?
I'm at home.
Oh, I see. So where are all the peeps?
People are at their hotel rooms
Oh, I see.
or
Oh, that's a
home.
whole different vibe, isn't it?
Oh yes. And
All right.
people are getting on to the webinar as we speak. So just so you're aware, we do have about 22 of our 50 participants are on with us.
Oh, great. Welcome, everybody.
And right at in just a few minutes, I will introduce you and we can get rolling.
Sounds good. So you're gonna
So
move the slides forward, or do you want me to? Because I can just share my screen here. I have the slides up and ready to run if you want to do it that way.
I think you can actually click on what I have given you control of my screen.
Oh yeah, I can control Amy Powell's screen.
Yes.
Unlimited power.
There you go. Yes. So
let's see.
If you just click on the screen, we find that a mouse works a little bit better, but I think that's
yeah.
Yeah.
Now I just have to figure out how to move backwards.
Yeah. I think it's just previous screen, and I can also move you all the way back. There we go.
Okay.
Yeah. Let me check the time. Yeah, just a couple minutes and we'll get rolling. Looks like we have about 31 on, and then you'll also be able to see the chats and the Q&A.
Oh, great.
If there are some questions for you.
Well, maybe you'll like it so much that Spice will be like this from now on every time.
Yeah, I don't know. It's got its pros and cons.
Not quite the same, though, is it?
No, it's not. It is not. We do have an occasional wind blowing through and kind of rattling my internet cords at home. So I don't know. Occasionally we've had a moment of lapse. So we'll just
Sure.
push through it.
Well, you got to have technical difficulties, otherwise it's no fun.
It's no fun without that. I think we'll just go ahead and get going. Welcome back, everybody, to our second presentation today. We have Dr. David Van Dyne with us to present on infectious diseases in the immunocompromised host. Dr. Van Dyne is an associate professor of medicine and serves as the director of the immunocompromised host infectious diseases section. He received his medical degree from the University of Amsterdam, the Netherlands, and completed an infectious diseases fellowship and PhD in investigative medicine at Yale. He has board certifications in internal medicine and infectious diseases, and his research interests include the study of multi-drug resistant gram-negative bacterial infections and infections in iatrogenic immunocompromised patients. Welcome, Dr. Van Dyne.
All right, well, welcome everybody. Please, by whatever electronic means possible, make sure that you interrupt me or make yourself heard and or seen if anything is unclear, and otherwise we should have some time to do questions at the end as well. And as Amy probably explained to you this morning and yesterday as well, normally this is obviously an in-person meeting, but we will make the best of it and bear with us through any technical issues that we may see. So I'm going to talk to you about infectious diseases in the immunocompromised host. And at University of North Carolina, we serve the following populations in that group. We're going forward without wanting to go forward. Anyway, those populations are solid organ transplant, bone marrow transplant, hematologic malignancies, and burn patients. There we go. So I'm going to talk a little bit about issues in those populations with neutropenic fever and neutropenia being the main one in the hematologic malignancies. All right, let's see if I can forward the slide one slide at a time. There we go. So whenever we talk about immunocompromised host, the timeline of infection is always crucial to keep in mind. And certain types of infections will show up at more or less predictable intervals after transplant. And here you see an example of that for solid organ transplantation, where this theory is really best established. So right after transplant, you see that people have the issues that are really related to their surgery and to being in the hospital. So they'll get multi-drug resistant organism infections like MRSA and VRE. They get infections that are related to the surgery itself, like anastomotic leaks. They may pick up C. diff. And then, of course, they can also have donor-derived infection. So if the organ that is being transplanted contains any infection, that will usually become apparent in that first month after transplant. Also, the recipient may come into the transplant with certain infections, and this may be a colonization that occurred pre-transplant or frank infection. Then in sort of the first 6 months, once that first month is over, it is really highly dependent on what kind of prophylaxis is being provided. So with prophylaxis, we see that it's mostly BK infections, C. diff, Hep C making a recurrence, and again, this is highly dependent, of course, currently on treatment, and this slide really predates the highly effective anti-Hep C treatment. And then after 6 months, you start to see more of a community-acquired pattern, but also still some opportunistic infections such as molds and aspergillus, nocardia, late CMV, etc. All right. So if we look specifically at viruses, we see that the now, can you guys see my pointer as well? Silence means yes, I guess. I'm not seeing the. Let's see what the chat has to say about the pointer. One person says no. 2 people say yes. All right, since this is voting Tuesday, the yes carried a vote. So I'm going to assume that you see my pointer. It's moving around like crazy now. No.
Yeah,
not seeing the pointer. Okay, then I will assume that you're not seeing it, and I don't really have any slides that I can't explain verbally, so we'll stick with that. Anyway, so what you see here is that HSV, or herpes simplex, is really the earliest virus to make its appearance, and of course the theme that you already see in this slide is that these are all viruses that are latent, that have latency, that so you either see the reactivation of the virus that the recipient is carrying, or this is a virus that is being brought in by the organ that is being transplanted. But these are generally not viruses that are hospital acquired. So again, HSV is sort of the first one, HSV 6 and 7 coming in later. CMV used to be known as the 40-day fever before it was clear what the cause was of that. So without prophylaxis in a setting of high risk for CMV, i.e. where the recipient does not have immunity against CMV, but donor brings in CMV with their organ, patients would get a fever around 40 days. And that was the first reactivation of CMV in that setting. You can see the line expanding out from CMV there, and CMV reactivation can really occur at any time, and that's obviously influenced by how long patients stay on prophylaxis. EBV tends to be a bit later, starting at about day 60, but really carrying on for a very long time. And then VZV, it's really something we think of later. Here they have it starting at about 3 months, and that's probably about right, but often we see this after a year or even after 2 years with the reactivation. So overall, we think about the risk in the sense of exposures combined with the net state of immunosuppression, and these exposures can be divided into donor-derived, recipient-derived, nosocomial, and community. So for donor-derived, and I'm just going to skip over these definitions, but just to know that there's a long list of how these donor-derived infections are defined. And when you look at the kinds of infections that can be carried by donors, not surprisingly, it really spans the spectrum. So almost anything can be found in organs and can then be transmitted on to the recipient, who of course is more susceptible around the time of transplant. And looking at these reports, the other thing to realize is that first, as I mentioned, you see that it really includes all types of species and pathogens, but also that the numbers are quite small. Now, what is generally reported are sort of unexpected donor-derived infection. So a lot of patients are transplanted who are, for instance, cytomegalovirus donor positive, recipient negative. All of those patients have a donor-derived infection with CMV. But as you can imagine, not all of those are in this table. So these are really the unexpected ones. So just to highlight some unusual donor-derived infections, these are some reports that were reported on various sort of dramatic donor-derived infections. One donor who had rabies was transmitted to 4 recipients. All 4 of those recipients died. There were 2 reports of West Nile virus, in which 8 recipients were involved. And of course, each donor would transfer organs to multiple recipients. You know, the lung would go to one patient, the liver would go to another patient, etc. LCMV has been reported, and in this case was interesting. They looked at the pet hamster of one of the donors and found that one to be positive for LCMV. So often these things can be very difficult to trace down, and in reality, these are just the kind of things that are just very difficult to prevent 100%. Balamuthia, which is an amoebic infection. Again, here you see the outcomes here. When we move on to recipient-derived infection, there are a number of scenarios in which this can happen. We sometimes transplant patients with active uncontrolled infection. We generally don't like to do that for obvious reasons, but sometimes the transplant is actually the cure for the infection, such as in an LVAD, or a left ventricular assist device associated bacteremia. Once you take the LVAD out, the bacteremia stops because the biofilm and the source is then removed, and you can treat people with antibiotics and get good outcomes that way. Similarly, if you have an infection that is only in the organ that you're going to take out, then also you will get a good outcome. Patients are obviously colonized with a variety of bacteria, and depending on how sick they've been prior to their transplant, they'll be colonized with more resistant bacteria. Recurrence of the indication for transplant and hepatitis C was, again, the most common scenario there, improving now with highly active anti-hep C treatment. Patients may be asymptomatically infected. Strongyloides is a good example of that, of patients who were born elsewhere, got infected as children, have the worms in their gut, and during immunosuppression can develop strongyloides hyperinfection syndrome. And then finally, patients can be latently infected, and TB is obviously the most common or best known example of that. And we test everybody for latent TB infection prior to transplant. And then obviously the herpes viruses that we already talked about. Another important source of risk comes from nosocomial infections, and these may be device-related, as you are well aware of. They can be related to the actual surgery itself. There can be outbreak settings for which transplant patients are specifically at risk if they happen in the transplant ward or in the specifically related to transplant surgery, and they often involve multi-drug resistant organisms. So here are some examples of outbreaks, and obviously in a infection prevention talk, you always have to put the picture of somebody washing their hands in. That's pretty much required, and I think this is the first picture that comes up on Google Images. So I think I've seen this person's hands, about 1 million times now in various talks. Pneumocystis is given here as an example in PEDS cases, and the pneumocystis has been somewhat controversial of whether there truly is person-to-person transmission, but there are several outbreaks now reported, and that does seem to be such a phenomenon. Here's another example of an outbreak. This was with Aspergillus, so mold, in a heart surgery ICU, and 3 heart transplant recipients were part of this, and developed invasive aspergillosis, and 2 of those 3 died. And Aspergillus, as you're probably aware, can often be implicated in construction, especially when the right precautions are not taken. This was from an outbreak in Pittsburgh, and there they had to stop the transplant program for a while until they had this resolved. So as an example of multi-drug resistant organisms, this was our experience in Cleveland, looking at Klebsiella pneumonia, bloodstream infections over a period of 6 years. We found in this period that there were 84 episodes of bloodstream infection in 65 recipients, and 23 of these were carbapenem resistant. So when we compare these carbapenem resistant ones to the carbapenem susceptible ones, the MDRO tended to show up earlier after transplant, which makes sense as a more nosocomial infection, and also tended to occur earlier later after admission, again going along with the theme of being a more nosocomial pathogen. And not surprisingly, the survival in those patients with carbapenem-resistant Klebsiella was unfortunately worse than what we saw with Klebsiella susceptible, carbapenem-susceptible Klebsiella. So, as we saw in the timeline, community-acquired infections are also important in solid organ transplant patients, and in fact in all immunocompromised host patients. And an important thing to keep in mind is that just because a patient is a transplant patient or is on immunosuppression, it doesn't somehow prevent them from getting common infections. And I sometimes have this discussion with our fellows where they make a very long differential diagnosis with all sorts of unusual opportunistic infections, but they won't put influenza on or something rather common. One thing to keep in mind, though, is that the manifestations can be different. So patients tend to be less likely to have fever and the full classic panel of symptoms. And I've listed here some common things, and again, we're about to head into influenza season, so that's always a big one. So looking here at the H1N1 experience with influenza, you see again that there is sort of a lower rate for a variety of symptoms that we classically think of with influenza. Here's our experience from Cleveland with Staph aureus bacteremia. Here we actually found a sort of an interesting phenomenon looking at mortality, in the sense that solid organ transplant patients tended to do better than all other controls together as far as survival was concerned. We never quite figured out why that was. We hypothesized in our discussion that this may be related to infectious disease physicians being very closely involved in the care of solid organ transplant patients, and after this paper came out, several other papers looked specifically at the role of ID consult and did indeed confirm that an early ID consult is beneficial in Staph aureus bacteremia. Looking at the net state of immunosuppression, finally, this involves more than just what immunosuppressive agent they're on. You have to think about how long are they getting it, what's the dose, what is the level. Some immunosuppressants last for a very long time, so some agents that are given for induction, for instance. And then there are also factors beyond the immunosuppression, immunosuppressive agents, and some of these are listed here that can have a severe impact on the net state of immunosuppression. So I'm not going to go through all of these here, but these are just listed here to give you a quick overview that there are many choices in commonly used immunosuppressive medications. And highlighting one specifically is alemtuzumab, which is often used at UNC. It's an anti-CD52 agent, and it results in a profound and sustained T cell, B cell, and NK cell depletion. So transplanters like it because it obviously protects against rejection quite efficiently. But it also, with that, can have an associated risk for opportunistic infections, as is highlighted in the table. And this risk appears to be highest when it's used in the setting of rejection, which may be part of the the timing of treatment itself, but also maybe part of the immunology of rejection, which has been linked to increased opportunistic infection risk previously. So moving on to stem cell transplantation, just to provide a little bit of background, the indications for stem cell transplantation are pretty varied. Most commonly involve malignancies such as leukemia, lymphoma, multiple myeloma. For some solid malignancies, they're done, but that's much less common. And there are also some non-malignancy indications for stem cell transplant, such as are listed here. There was some initial excitement about curing HIV by means of stem cell transplant, but that has pretty much gone away, I think. And then the rationale for how stem cell transplant works obviously differs by why you're doing it. So in malignancies, you're heavily dependent on a graft versus tumor effect, where the immune cells that you're bringing in through the stem cell transplant will find those malignant cells and kill them. Similarly, in malignancies, it will also allow you to dose escalate your therapy and your chemotherapy so that you can kill more of those malignant cells and then rescue the marrow with stem cell transplant. In case of hematologic deficiencies, it's more about replacement therapy, where the new cells coming in are going to make that crucial enzyme or reconstitute a cell line that you don't have, and similarly with gene therapy. Looking at graft versus tumor effect, you obviously want that maximum graft versus tumor effect with a minimum graft versus host effect, and that's something that is quite difficult to balance, given that tumor cells are obviously derived from host cells and are quite similar to host cells. There are different types of stem cell transplantation. They can either be allogeneic, meaning you get somebody else's cells, versus autologous, meaning you get your own cells back. The sources can also be different. It can come classically, we're coming from the bone marrow, hence the short of BMT or bone marrow transplant. Most of the time now mobilized peripheral blood stem cells are being used, and in some instances umbilical cord blood cells are used. Any transplant is preceded by a conditioning phase during which disease is eradicated, or ideally, or at least in the number of bad cells is decreased, and also the host immunity is being suppressed. And this can be done with a number of modalities which can be used either alone or in combination, such as radiation, chemotherapy, and biologics. Now, the more you use this induction and conditioning, the less you need the graft versus tumor effect, but the higher your toxicity is going to be. So if you have a very low intensity conditioning, then the toxicity associated with that is going to be lower, but you need a lot of graft versus tumor effect to eradicate all the tumor cells. If you crank up the intensity, you get more toxicity, but need less graft versus tumor effect to come to a cure. Immune reconstitution after a stem cell transplant is quite prolonged. We often monitor neutrophils and the neutrophil count as the main issue, but that does come back fairly quickly. But as you can see here, for instance, looking at the blue line for plasma cells, and then a more extreme, even the red line for CD4 T cells and natural killer T cells, those really take up to months to years to be reconstituted. For stem cell transplant, there's also various timelines that will predict when you get what types of infections in the pre-engraftment period, where you have low neutrophils, you're at high risk for various bacterial infections, and it's really quite center to center dependent on which are predominant as far as whether these are gram-negative or gram-positive. Viruses are really predominated by herpes simplex in this early period, and Candida is the most important fungus, with Aspergillus coming on slightly later during the neutropenic phase. And post-engraftment, you still see some Aspergillus for fungus. Candida remains important. Cytomegalovirus starts rearing its ugly head, and the bacterial infections start dropping off. Then in the late phase, you see that the encapsulated bacteria become especially important. VZV, similar as after solid organ transplantation, this is really a late complication. Aspergillus comes back again, and we start to see pneumocystis as well. And I just made this table to go over the risk for infection as it relates to various characteristics of transplant. So an allogeneic transplant is a higher risk than autologous. If the donor is unrelated, then you have a higher risk than when they're related. Similarly, the more HLA mismatched the donor is, the higher the risk is. If it's a cord blood, it's higher risk than peripheral blood. If the graft is T-cell depleted versus no manipulation is associated with higher risk. If there's a full intensity conditioning regimen, there's a higher risk. And obviously, if there's a need for further immunosuppression, such as in the treatment of graft versus host disease, that is associated with a higher risk of infection. And finally, graft versus host disease itself, especially when it's moderate to severe, is associated with a higher infectious risk. And talking a little bit about graft versus host disease, this is a common complication of allogeneic stem cell transplant. And again, the reason that it's so common, as you can understand, is related to what I was talking about earlier, that you need that graft versus tumor effect for the transplant to be effective against the malignancy. So not surprisingly, graft versus host disease is quite common, often impacting the skin and the GI tract. And you see here the various gradations, with very severe graft versus host disease only having a 5% 5-year survival. Steroids are most commonly used in the treatment of graft versus host disease. It can be used topical or systemic. Then calcineurin inhibitors like tacrolimus may be added to that. And there's a number of alternative approaches for steroid refractory graft versus host disease. Looking specifically at bacterial infections, so again, it depends somewhat center to center in what predominates versus gram-positive versus gram-negative. C. diff, a big problem in various stem cell transplant units. And then later we start seeing the encapsulated bacteria and as well as nocardia. Bacteremia, quite common after stem cell transplant, and more common in allogeneic stem cell transplant. So here you see the days to first bacteremia. On the top, you see all bacteremias. On the bottom, they've excluded negative staph, which obviously often are skin contaminants and don't reflect true bacteremias. But still, you see a cumulative incidence in allogeneic transplants of 29%. Looking then at fungi appearing at various times after transplants, as well as viruses. We mentioned Candida and HSV coming on early, Aspergillus, CMV, and EBV coming on later. BK virus often presenting as hemorrhagic cystitis that can be quite painful in this population. And then later on, after transplant, we keep seeing Aspergillus, start to see other molds, also pneumocystis, mostly related to graft versus host disease. In the viruses, CMV, VZV, EBV, and then obviously independent of time, respiratory viruses along the same lines as I mentioned before, and that you're not protected from influenza if you have these things going on. Overall, Aspergillus is the most common fungus, closely followed by Candida, but there's a big tail of sort of more unusual molds, including agents of zygomycosis. And here is just this same timeline, but broken up by organ system, and starting with the pulmonary system. And the reason that I like this slide and put this slide in is that there are also many non-infectious complications going on during this same time, like congestive heart failure, diffuse alveolar hemorrhage, bronchiolitis obliterans, etc. So often we find ourselves in a situation trying to figure out whether it's infectious, non-infectious, or a combination of those two. Moving on to the GI tract, again, sort of a similar theme where there are many non-infectious complications in addition to infectious complications, and trying to figure out the differential between those and the relative contributions. This is also where the C. diff diagnosis becomes more difficult. As you know, a lot of patients carry C. diff, but are not actively infected with C. diff, but do have positive tests for C. diff. So if you have a chemotherapy-related diarrhea and you start checking everybody for C. diff, it becomes difficult to interpret those tests. So specifically looking at types of infections that can impact the GI tract, again, we look at the same viruses that we've talked about already. Candida can obviously give you an esophagitis. Various bacteria can cause infectious diarrhea. Also, for diarrhea, C. diff is obviously the #1 concern, but you see that there's a whole range of various types of pathogens that are in the differential there. Again, to emphasize that non-infectious GI complications can be quite common. Neutropenic colitis occurs up to 30% of neutropenic patients, and then graft versus host disease, as we discussed, can also go to the GI tract. This is a slide looking at the central nervous system complications after stem cell transplant. And again, the same theme where you have infectious complications such as bacterial meningitis, fungal meningitis such as crypto, virus reactivations, but also graft versus host disease, hemorrhage, infarction. You can develop PRES from calcineurin use, etc. And here are just some pictures showing, a brain abscess as well as Epstein-Barr virus related PTLD or post-transplant lymphoproliferative disorder. This is just another example of an outbreak, this time in the stem cell transplant. And what is interesting here is that you see the clear role of construction that we talked about before. So as you know, with construction, Aspergillus spores will increase. And here you see a clear relationship that if you have vulnerable hosts with more Aspergillus spores present, then you will start to see more cases. And you really need to put infection control measures in place, really ideally prior to starting construction. Moving on to neutropenia, we have a large study called the MASK study, from which a lot of our knowledge comes about neutropenia and sort of the prognosis. In this study, about a quarter of patients had bacteremia, 84% of patients had resolutions, 11% had at least one serious complication, and 5% died. These are some guidelines that you can refer to, and in these guidelines, they've divided patients up into sort of high-risk neutropenia, and these are the patients that generally come into the hospital, versus low risk. You can also use the score derived from this MASK study. The score is a little bit counterintuitive, where a lower score is actually worse. So a lot of these things are framed in sort of in a negative way, like no hypotension gives you 5 points. And I'm not exactly sure who came up with that, or why they thought that was a handy way to do it, but so be it. But here you see that if you have these high scores, and which means that you're low risk and you don't have any bacteremia, then your risk of death is quite low. It does go up if you do have bacteremia in all categories, but you see it tracks quite nicely with this MASK score. And in the lowest group, so the highest risk group of less than 16, you see that in all 4 categories of no bacteremia, gram-positive or gram-negative bacteremia, polymicrobial bacteremia, mortalities range from 20 to 40%. So this risk is important because high-risk patients need to come into the hospital and get IV antibiotics. And these tend to be your patients who are being prepped for a stem cell transplant or going treatment for leukemia. Low-risk patients you can treat as outpatients, can get oral antibiotics, and tend to be patients with solid tumors. So a lot of recommendations are present for managing patients with febrile neutropenia. Obviously, hand hygiene is number 1, 2, and 3, but there are a lot of specific recommendations for these patients. So these should be in private rooms, HEPA filtered, plants and fresh flowers should not be in those rooms, and apologies for this typo here. And another sort of an important issue that I don't think has been really solved is, especially during respiratory viral season, what do healthcare workers do if they have the sniffles? And obviously these can be quite mild for the healthcare worker and really, be on the level of a cold, where people would say, I can easily come to work, but you really don't want to expose these vulnerable patients to, be it RSV or adenovirus or, influenza can be quite mild as well, of course. So as far as feeding these patients, you want to, in general, cook the foods well, avoid these luncheon meats, and you can use raw fruits and vegetables only, but they have to be well cleaned, obviously. Skincare, very important, and there's a long list of sort of recommendations here, but you really see that if there is a lack of attention to this, you pay a price quite quickly. Generally, you want to avoid pets and animals, and we already talked about avoiding plants. The patients who are, healthcare workers or visitors who are sick or have other diseases really should not be near these patients. And obviously, all healthcare workers should get their flu shot. As far as routine surveillance cultures, those are generally not recommended to see what kind of bacteria you have around. We talked about Aspergillus outbreaks, and you want to be very careful again with renovation and construction. The hospital air should be filtered, HEPA filters for stem cell transplants, and when patients leave that floor, they must have respiratory protection. Legionella. Generally, you want to avoid showers during neutropenia, and if Legionella cases are seen, then you want to start looking at your water water supply. So when what should you do when there is construction or renovation? The key thing is really to get those barriers up and really make sure that they are maintained. This involves, as you guys know better than I do, really being proactive and being immersed with these teams that plan these kind of interventions, because it's not enough to just have a policy. You have to actually have boots on the ground and make sure that these directions are being followed. And then you want to make sure that the ventilation system doesn't bring the stuff from the construction area to other locations. If there are immunocompromised patients in at-risk areas, you want to move them to somewhere else. After construction, you want to clean it. It may be a good idea to look for airborne fungal infections. and as well as look for airborne fungal levels, but this really depends on the extent, I think, of the construction that's being done and the number of days and really what you can do about it. So just touching base on latent infections, there are a number of patients that should be screened for latent infections, and the reason is that you can then identify them early and treat them early or provide therapy to suppress infection. Lots of latent infections are present. We've talked about a good number of these already. So the last topic I want to cover is burn patients. Burn infectious disease is really a sort of a nascent science and has a limited literature to support its recommendations. And for the most part, from an infection control perspective, we do try to use paradigms that have been well established in other fields and especially in other ICU settings. But there's often some concern that specific recommendations for non-burn patients might not be extrapolated to burn patients. And obviously the key difference in this population is that they have a large open skin area that can serve as a portal of infection and that can also impact the rates of device-related infections such as Lyme associated bacteremia. So there are a number of ways in which infections can be prevented. We use a lot of topical agents in our burn unit. We use occasional systemic antimicrobial prophylaxis. There's a lot of controversy about this. Obviously, in the classic infectious disease paradigm, there's a very limited role for antibacterial prophylaxis, even though we're much more comfortable with antiviral prophylaxis. But often we see that if you try to do antibacterial prophylaxis, you'll just select for more resistant strains. Wound care, obviously crucially important. We've moved from doing universal isolation precautions in our burn unit to just doing them as needed and having standard precautions in other patients. And then the frequency of line changes is also sort of a hot button issue where currently we're doing them every 3 days in our burn unit, which is obviously against recommendations for other ICUs. So this is a paper looking at risk factors for nosocomial infection. And really, when you start to look at the burn literature, a key factor for just about anything, whether it's mortality, whether it's nosocomial infection, whether it's renal failure, is not surprisingly the size of the burn. If you have a small burn, then it's relatively less likely that bad things will happen to you. Whereas if you have a very large burn, again, not surprisingly, you are much more likely to get into trouble. Here, this is shown as percent TBSA, which is about in the middle of this table under the injury type, and TBSA stands for total body surface area. So if your percent TBSA is 100%, then every part of your skin is burned. If it's 50%, then half, and they have maps to say, okay, the front of your arm accounts for 5%, for instance, et cetera, et cetera. There are some guidelines looking at burns from, and these are from resulting from combat. Um, and again, you see that topical antibiotics are used in basically in all levels of wounds. Here is some experience from our own burn unit, and our infection control group has been working tirelessly and continues to work tirelessly to try to keep these numbers down. You see here in these in this the unbroken line, you see the rate of central line associated bloodstream infections between 1999 and 2012, and the dotted line reflects all other ICUs. So the trend was certainly in the same direction for all ICUs, but you see that whereas they end up in the same spot, they started off much higher in the burn ICU. And then the shaded bars show what proportion of those are Staph aureus line-related infections. And you see that they really start off pretty high and decrease also significantly, and that's I think reflective of a national trend of less Staph aureus infection. And these were some of the interventions that were performed at UNC to get to this result. As always with infection control measures, it's always hard to say, you know, what is it that's really providing the effect, because multiple things are done, and the there's an overlap in getting these activated in the burn unit. So I'll stop there, and I'll take any questions that you may have. See if I can get the chat back up. Where is the chat?
Upper right. Let's see.
Before I saw it on the bottom of my screen, but seems to have disappeared. Anyway, Amy, if you see any questions, if maybe you can just repeat them back to me while I try to figure this out.
Be happy to. I have the chat pulled up and not seeing anything at the moment, and just the earlier.
Okay, and obviously people can speak up too, I think, right? Just with audio or no?
Yeah, I think they can.
Whether they want to is a different question, of course. Whether anybody's still awake out there.
Any questions for Dr. Van Dyne?
All right, then I'll, oh, here we go. Here, the chat is coming up. Is the potential of this applying to tissues used in orthopedic procedures? And this comes from Bonnie Koski. Bonnie, can you just explain what you mean by this? Of what applying what to tissues used in orthopedic procedures as far as donor-derived infections? Yeah, so in general, the use of tissues is generally associated with lower, although albeit not absent, risks of infections. And there have been various infections that have been reported with the use of these types of tissues. Often they're sort of devascularized and sort of processed tissues, then that sort of decreases the risk. But again, the risk is not zero. And I think there have been, I don't want to lie to you, but certainly viral infections. And I thought there was a report of a prion outbreak, but I might be mistaken there. But in general, the answer is yes. And I see a question from Elizabeth McLean, or if I'm pronouncing that correctly, and if I'm not, I apologize, about the central line over guide wire exchange every 3 days and new site every 6 days. Is this still best practice? And this is specifically for the burn unit. So let me give you sort of a two-part answer. This is certainly not the recommendation from Shea. The Shea recommendation is to change central lines only when indicated. So only when, if there's a reason to change them out. And this is based on some randomized trials where they looked at changing them out, you know, at specific time intervals versus changing them out only when indicated. So that's really I would say the official answer. Now, when we've discussed this with our burn surgeons, and of course we've discussed this quite extensively at various time points, their reply is, okay, but those patients that were in those trials were not burn patients, did not have extensive skin disease, and really their CLABSI sort of pathogenesis is quite different. And that is a fair point, I think. Now, whether that means that this paradigm does not apply to burn patients, we don't know. So I think the evidence is lacking. They've done a survey of burn units to see what people do, and it's all over the place. Some people do something like what we're doing, guide wire exchange every 3 days, new site every 6 days. Some people do a new stick every 3 days. Some people only do a new site every 6 days and don't do a guide wire exchange. Some people just leave the lines in and change them when needed. So there really is no consensus and therefore no best practice. All I can tell you is what we're doing at UNC.
Okay.
All right. Thanks, Bonnie.
All right. We appreciate your presentation, Dr. Van Dyne. Thank you very much.
It's my pleasure, but next time we got to do it in person again.
Yeah, definitely.
That's definitely more fun.
Yeah, I think that's better for everybody. All right. Well, thanks so much to the group. We'll be back on at 11 with another webinar. We'll see you shortly.
Thanks, Amy.
Thanks.